Morning everybody. Today I'm going to be talking about malignant bone tumours. Okay, so rather than doing an overview like we've had for the last two sessions on workup of bone lesions and also on benign bone tumours, I'm going to be a little bit more specific today and go through osteosarcoma in a little bit of depth, and then go into Ewings, Chondrosarcoma and multiple myeloma. Osteosarcoma is a spindle cell neoplasm that produces osteoid, so that's the defining feature of osteosarcoma. It's an osteoid producing tumour. It's the most common primary bone tumour, excluding myeloma. There's a bimodal peak in its incidence, most commonly in the second decade, but there's also another peak in later life that's usually associated with Paget's disease, which I'll go into. Slightly more males are affected than females. It's associated with Framini syndrome and retinoblastoma, which are both associated with a loss of the tumour with the tumour suppressing gene P53. It's also associated with radiotherapy in Paget's, especially in later life. Osteosarcoma tends to present with localised pain and swelling. There's usually not any systemic features present. There's usually no history of fever or weight loss. Examination often reveals a large, soft tissue mass. The areas of bone affected tend to be metaphyseal in origin, distal femur most commonly, but also proximal tibia and proximal humerus are commonly affected. By and large, bloods when a patient presents with osteosarcoma are normal. So usually ALP, LDH and ESR are normal, but occasionally they are high, and a very high LDH is associated with a poor prognosis. Metastatic disease that can be seen is only present in 15% of presentations, and most commonly the lung, but also distant sites, distant bony sites. This is a typical X-ray of the osteosarcoma, so it's affecting the most common site, the distal femur, showing mixed lytic and sclerotic components. There's lifting of the periosteum, so-called Codman's triangle here. There's cortical breach, ill-defined margin, and soft tissue involvement as well. And there's also bony calcification of the soft tissue, which causes the so-called sunburst effect. So X-ray findings consist of destruction of the normal trabecular pattern, indistinct margins, mixed lytic and lucent areas, new periosteal bone formation, the lifting of periosteum, and the soft tissue ossification. Differential diagnosis at this stage should be other malignant tumours, benign tumours, and also non-tumour pathology such as osteomyelitis. Here's another bone scan and also a plain film of a less threatening looking osteosarcoma of the proximal tibia. But as you can see, there appears to be cortical destruction and mixed lytic and sclerotic appearance to that lesion. So the workup should be done for all patients in a very routine way. So there should be an MRI done of the entire bone. It's been shown that MRI is better than CT at defining the soft tissue extension of the lesion, and also for picking up soft tissue pathology and medullary skip lesions. So if there's a proximal lesion, if there's an area of normal bone and then another lesion further down the shaft, MRI is better at picking that up. All patients should have a CT chest as the most common site of metastatic disease is the lung, but this has shown that it may underestimate the extent of pulmonary involvement. Bone scan is probably the most sensitive test for evaluating the rest of the skeleton, and positron emission tomography has its role, can be used rather than bone scan in that initial workup, but it's probably less sensitive, but can be used for monitoring preoperative response to chemotherapy. The problem with saying that one's better at this and one's better than that is that it's also written that you should pick one and choose one throughout the treatment process. So if you're happy to accept a little less sensitive at the start, PET's going to be more sensitive throughout the course of treatment in regards to your response to chemotherapy. Once you've done that workup, you need to go ahead and do a biopsy. So in terms of guidelines for doing a biopsy, I don't think this has been covered in the last few weeks. The biopsy should be done by the treating surgeon who's going to do the definitive operation. It should be done in theatre under general anaesthetic. Usually there's no preoperative antibiotics given. There is a tourniquet used, and I think this is the important part of the biopsy that you all learn, is that it should be an intracompartmental approach, intramuscular approach with no neurovascular exposure. The excision should be longitudinal, so it becomes extensile. You should confirm the sample with immediate frozen section to make sure you've got the appropriate sample for later pathological testing. If a large cortical window is made, then you should use bone cement to plug up the defect. The tourniquet should be deflated before closure, and then meticulous hemostasis should be adhered to in order to prevent a post-operative hematoma, which by definition is tumour. The layers should be closed independently and subcuticulous sutures used. A drain shouldn't, if used, shouldn't be used through a different path through the muscle. It should come out through the primary wound. And the definitive tumour resection must take that entire tract out when you go back in. So this is the type of pathology osteosarcoma is associated with, or histology. There's spindle cells producing osteoid. So this is osteoid here, and these are the tumour cells producing it. And then it can be, this is in classic osteosarcoma, this can be further defined into whether the predominant matrix that the cells are making. So they're all making osteoid, but they can be further grouped into osteoblastic, chondroblastic, or fibroblastic. So mainly osteoid producing, mainly cartilage producing, and mainly fibrin producing. They're all classified as your usual high-grade central osteosarcoma. Not particularly, no. They're all high-grade tumours, and they're all your classic osteosarcoma that makes up about 80% of cases. So that classic osteosarcoma is grouped into the intramedullary osteosarcoma group, as is cholangiotic, which represents less than 4% of lesions, but up to a quarter present with fracture presentation. So it's an aggressive, eccentric, very lytic lesion, and it's associated with dilated hemorrhagic cavities on microscopy. Low-grade osteosarcoma is quite rare, and it's less aggressive, and it looks a little bit like fibrous dysplasia on plain film. And small cell osteosarcoma is also quite rare, but has a similar appearance to Ewing's under microscopy. Osteosarcoma also exists as a different entity as juxtacortical or surface osteosarcoma, the most common of which is parosteal. So parosteal osteosarcoma, I'll go into a little bit more detail on the next page, but occurs at about 5% of osteosarcomas. And then there's periosteal, which has quite a typical appearance, but it's actually associated with the cortex rather than the medullary canal. And then there's high-grade juxtacortical osteosarcoma. So this is a periosteal osteosarcoma. It's a low-grade tumour, so not a particularly active or highly replicating tumour. It presents with often affects the distal femur, and when it does, it affects the back of the distal femur and actually presents with a painless block to knee flexion. Commonly in the 3rd decade of life, the intramedullary canal is spared, and this densely ossified lesion wraps around the bone. It's associated with a so-called string sign, so it's not actually, so it's around the periosteum, and you can see a thin line, lucent line between the cortex and the actual tumour, and that's quite pathognomonic of the tumour. It's slow growing and is treated usually by wide excision only and doesn't require chemotherapy like the rest of the osteosarcoma group. Staging for bone tumours is relatively straightforward. It's the Ewings staging, and essentially it's divided into grade and then into whether there's extracortical involvement. So stage 1 is low-grade tumours and stage 2 is high-grade tumours. They get a B denomination if they extend through the cortex. So that's not a juxtacortical tumour, that's something that breaks through the cortex and is associated with cortical destruction. Grade 3, or stage 3 tumours are ones with any distant metastases. The most common presentation for an osteosarcoma is high-grade tumour that extends through the cortex, so that's when it's usually picked up. Your treatment algorithm is accurate staging, which includes your biopsy, neoadjuvant chemotherapy, 8 to 12 weeks prior to tumour resection. It's then important to restage the tumour, and that's done dependent on its response to chemotherapy, so looking at how many of the cells are necrotic after removal of the tumour. Wide surgical resection and then adjuvant chemotherapy for 6 to 12 months. So the restaging or response to chemotherapy, that stage is also done using the PET scan or repeat bone scan, as we talked about earlier. So I think chemotherapy initially came about because there was delays in getting patients to theatre to do the definitive surgery, which was thought to be the best and most likely thing to have a response in patients. So historically, everyone got amputation that presented with osteosarcoma, and if there was going to be delayed, they started thinking what else they could do in that interim period before they got to surgery, and that's when chemotherapy started showing that it has a role in osteosarcoma. So multiple agents are used. The outcome is best predicted by the response to chemotherapy. So some osteosarcoma tumour cells have been associated with having a P glycoprotein pump that actually extrudes the chemotherapy agents from the cell. And if a tumour is killed by the chemotherapy agent preoperatively, so if there's greater than 90% of cell death at tumour removal, there's an association 75% survival at the 10-year mark. Surgery is done 3 to 4 weeks after the last dose of the chemotherapy, and it's restarted 2 weeks after surgery. Surgical options. There's limb salvage versus amputation. So salvage is thought to be applicable in more and more cases, and up to 85% of cases are appropriate for limb salvage techniques. Amputation is appropriate when resection will leave a non-functioning limb. and there's actually similar survival rates between the two, and that's probably a reflection of appropriate selection of patients for both, and also the fact that limb salvage surgery really does work if chosen in the right patients. So there's a number of options for salvage. You can use an osteoarticular allograft, which is associated with a high fracture and failure rate. Intercalary allograft, so replacing a segment with allograft, pure allograft. And then there's more the prosthetic type approach, so you can use an endoprosthesis or an extendable endoprosthesis in skeletally immature children if the growth plate's involved. You can use allograft prosthesis composite, which we commonly use for failing total hips and long stem hip replacements. You can use an arthrodesis to replace the affected part of bone and joint, or you can do a rotational plasty, particularly when the site affected is the distal femur or proximal tibia. Free vascularized fibular transfer is also described. Resection of the metastases at the same time is associated with better survival. So I think that's when, again, the importance of having a tumour-centred workup and treat these patients. So I don't know much about rotation plasty, and I don't know if this is anything that's really commonly done, but I thought this picture looked excellent, so I wanted to include it. So prognosis, prior to chemotherapy, only 10 to 20% of patients were surviving at 5 years with amputation alone. Now, the most common presentation of stage 2B tumour, 60 to 75% of patients have a 10-year survival, and even with distant metastatic disease, a presentation of 10-year survival of up to 30% is seen. Now, the things that are associated with a poor prognosis, apart from the obvious metastases, are axial skeleton involvement, a raised ALP at presentation, skip lesions, lymph node involvement, and also the most sensitive is probably being a poor responder to chemotherapy. I'd also like to talk a little bit about Ewings sarcoma. So Ewings sarcoma is a tumour of round cells which are of an uncertain origin. It's thought that they may be neuroectodermal cells. They are associated with a translocation that is part of the tumour transformation of these cells into tumours between the 11th and 22nd chromosomes. The most common sites affected include the distal femur, pelvis, humerus and scapula. The age is approximately patients in the late teens, early 20s, with again a slightly male dominance. Patients with this tumour can present with pain and swelling, but also in a larger number than osteosarcoma, there is a certain group of patients that present with fever, weight loss, malaise. It's associated with high ESR and LDH, and also anemia and leukocytosis at presentation. Again, the grading of the stage of the tumour is most commonly a high-grade tumour with involvement and cortical destruction at the time of presentation. So these are some X-rays of Ewings sarcoma showing a lytic type lesion with permeative destruction, so ill-defined borders of the tumour and a moth-eaten appearance. And there's classically, I'm not sure these pictures particularly show it, but onion skinning of the periosteum, so laminated periosteal reaction associated with the tumour. If you want to go back into your university days, there's a translocation here between the 11th and 22 chromosomes. So the 11th looks slightly longer and the 22nd chromosome looks slightly shorter. Okay, that's about the extent of my knowledge. And then there's the light microscopy appearance with lots of small round cells with very large nuclei. This can be a difficult cancer to diagnose by the pathologist. and often a lot of cytogenetic testing is required to help stage and grade the tumour. A bone marrow aspirate from a distant site can also be done for staging to look for any distant spread of the tumour. But the treatment algorithm is similar to osteosarcoma. So again, it consists of staging preoperative chemotherapy, restaging tumour excision, and then chemotherapy again. The prognosis is relatively poor in comparison to osteosarcoma, so approximately 60% have 5-year survival, and it's poorer if the axial skeleton is involved. Chemotherapy alone is associated with a 25% recurrence of the primary lesion, but only 5% if surgery and wide local excision is performed. Chondrosarcoma is the third most common primary malignant tumour. Again, it's associated with translocation in the cytogenetics in approximately a quarter of the tumours. It has a peak at 50 years, and again, more males affected than females. It's a cartilage-producing tumour, so no osteoid is produced by this tumour, and it commonly affects the pelvis and proximal femur. It is usually, so the standard of chondrosarcoma is a low-grade lesion, so it is a slow replicating tumour. And the so-called primary chondrosarcoma, which is thought to rise relatively from a tumour from the very start, whereas secondary chondrosarcoma is associated with a pre-existing osteochondroma or an endochondroma. It can also be associated with previous fibrous dysplasia, Paget's disease, or radiation. Chondrosarcoma, I think more than a lot of other tumours, is often a diagnostic dilemma, picking up the malignant features. So the histology can look identical to an endochondroma under the microscope, and a lot of it is actually still done on the plain film appearance and the location of the tumour to determine the malignant potential of the tumour. So a chondrosarcoma, as you can see, looks like an endochondroma. The malignant features on plain film include additional cortical thickening and periosteal reaction to a standard endochondroma, so-called endosteal scalloping around the tumour. Cortical destruction, if present, is a sign of chondrosarcoma. A soft tissue mass is usually present in chondrosarcoma, but definitely not in endochondroma. And the larger the size of the lesion, the more likely it is to be malignant. Treatment of this low-grade tumour is wide resection. You can also use intralesional curetting if it's a small grade 1 lesion, which I found interesting. It's resistant to chemo and radiotherapy due to its nature of being slow replicating, and classically chemotherapy and radiotherapy target highly fast replicating cells. The prognosis is good, 90% at 5 years for low or moderate grade, and the rarer tumours that are high grade do behave quite aggressively, and there is a poor prognosis. Myeloma is the most common bone malignancy. It's a neoplastic proliferation of plasma cells. These plasma cells produce heavy chains, so immunoglobulins G, A and M, and also light chain, which is your Bence-Jones protein, which are kappa or lambda immunoglobulins. It's most commonly presents as multiple myeloma, and that's what we see more commonly, but also can exist as a solitary lesion called a plasmacytoma. It commonly affects patients over 40 and in later life. Males, again, are more commonly affected, and African Americans are twice as likely to be affected by multiple myeloma. Patients can present with pain. They often present with pathological fracture or impending pathological fracture, and that's how we often see these patients. Or they can relate to symptoms related to the cell progression, anemia, renal failure, and hypercalcemia. Bloods are always abnormal for multiple myeloma. You can get anemia, a raised creatinine, a raised calcium, ESR, serum and urine electrophoresis should also be performed when working up these patients. It's a very aggressive cancer. The median survival is 3 years, and this is usually associated with a progressive renal failure and hypercalcemia. The X-ray appearance of multiple myeloma is multiple punched out lytic lesions. There's not your normal tumour looking sclerotic reaction or soft tissue reaction surrounding these lesions, and they can have a soap bubble like appearance as well within the lesion itself. An interesting thing that I found, which I didn't know, was that up to a quarter of the patients with multiple myeloma don't have any discrete lesion throughout the skeleton, rather diffuse osteopenic and osteopenic changes. And they also can present with pathological fracture or advanced crush fractures and almost flattening of vertebral bodies, and a pepper pot skull appearance, which I think most of you have seen X-rays for. The bone scan is usually hot, but is classically, and we know that it can be cold in up to 30% of patients. If the bone scan is negative and you're thinking of multiple myeloma as the diagnosis, you don't have any real idea of where to image, so a skeletal survey is indicated if you have a cold bone scan and you're still thinking of multiple myeloma. Diagnosis of multiple myeloma is judged on a set of criteria, which includes the major criteria. If any of these are positive, the patient has a diagnosis of multiple myeloma. So this includes biopsy or confirming plasmacytoma or greater than 30% of plasma cells on bone marrow aspirate. So this is often where the orthopaedic surgeons become involved when the diagnosis is still being worked out, and occasionally a biopsy is needed to confirm diagnosis. If more than 3 of the minor criteria are present, the diagnosis is also confirmed as multiple myeloma. Treatment consists of chemotherapy, steroids and cyclophosphamide or methylene. Radiotherapy is often used to treat the pain and to reduce the bulk of the lesion, and the orthopaedic role in treatment of myeloma is often either confirming the diagnosis, which involves biopsying the isolated lesion, or treatment of impending or existing fractures that occur. As I said earlier, multiple myeloma is very aggressive and the prognosis is poor. Thank you very much for the talk this morning.